There's a statement I hear from patients almost every week. My doctor told me there's nothing more that we can do for my neuropathy. And here's the honest answer. Within the framework most doctors are working from, that's often true. The problem isn't what your doctor said. The problem is the framework. Today, I'm going to tell you what the framework is actually missing. In 35 years of practice, with the last several years dedicated entirely to patients with peripheral neuropathy, I've seen what happens when patients get a root cause workup versus when they get only a symptom management process. The outcomes are not the same. I'm going to break down exactly why standard treatments has a ceiling and what the root causes it's missing and what a different kind of evaluation actually looks like. We'll go through what gabapentin and Lyrica actually do, the 4 root cause categories almost nobody is testing for, and why nothing more we can do often means nothing more within this framework. What standard treatment actually does. Let me start with what's actually in the toolbox most doctors are working from. The first line of drugs for neuropathy, gabapentin and Lyrica, duloxetine, amitriptyline, they all work on the same principle. They manage pain signals. Gabapentin binds the alpha-2 delta-1 subunit of calcium channels. What that means in plain terms, it reduces the excitatory signal that a damaged nerve is sending. It's not doing anything to the nerve itself, it's just turning the volume down. Lyrica, pregabalin, works on the same mechanism, different pharmacokinetics, but the same target. Duloxetine works at the brain level, serotonin and norepinephrine reuptake inhibition, which raises your pain threshold. You're still getting the same signal, but you're just less sensitive to it. Amitriptyline, the old tricyclic antidepressant that gets used for nerve pain, central pain processing modulation, same idea. All 4 are managing the pain signal. None of them are doing anything to the nerve itself. None of them address nerve repair, vascular supply to nerves, oxidative stress on the nerves that's protecting the myelin sheath, or nutritional availability for nerve maintenance. The signal is just being managed. The source is not. Now, here's a number I want you to understand. It's called NNT, the number needed to treat. NNT is how many patients need to take a drug or a patient to get meaningful relief. For gabapentin, that number is somewhere between 3 and 8. What that tells us is this. If you have 10 patients in a room all on gabapentin, somewhere between 3 and 4 of them are getting at least 50% pain reduction. The other 6 or 7 aren't. Those 6 or 7 patients are not failing gabapentin. Gabapentin is not matching their mechanism. They have a driver behind their neuropathy that this drug was never designed to address. And yet, they stay on it for years, sometimes even decades. Because within the symptom management framework, there isn't another option being offered. So, what is the driver? Here are the 4 root cause categories that standard treatment doesn't screen for and doesn't even really treat. The 4 causes standard treatment really miss. I want to be very clear about what this section is and what it isn't. This is not me telling you to take supplements instead of seeing a doctor. This is a clinical framework, 4 categories of root causes that exist in the literature that I evaluate, and really for every new patient in the standard treatment systemically skips. Root cause 1, oxidative stress. This is one of the most common drivers in diabetic neuropathy specifically. When blood sugar runs high over time, it generates free radicals, and those free radicals attack the myelin sheath, the protective sheath around the nerve fibers. Think of the myelin like insulation on an electric wire. When oxidative stress degrades it, the nerve signaling becomes erratic and painful, and eventually just goes quiet. This is an active, ongoing process. As long as blood sugar is dysregulated, and here's what matters really is gabapentin doesn't touch the oxidative stress. Neither does Lyrica. They're managing the symptoms of the process that is still running in the background. Root cause number 2, metabolic and vascular insufficiency. Peripheral nerves depend on blood supply. There are tiny vessels called the vasa novarum that feed the nerve directly. When circulation is compromised, blood sugar dysregulation, insulin resistance, poor vascular health, those nerves are operating in an oxygen-depleted, nutrient-depleted environment, essentially choking and suffocating. You can turn down the pain signal all day long, but if the nerve supply isn't adequate, the nerve is still degrading. Metabolic optimization, getting blood sugar trajectory under control, changes the chemical environment the nerve is actually living in. Root cause 3. B12 and nutritional deficiency. Myelin maintenance requires B12. This is basic nerve biology. The problem is that B12 deficiency is extremely common and frequently missed. Metformin, one of the most prescribed drugs for diabetes, depletes B12 over time. Proton pump inhibitors, the acid-blocking drugs, deplete B12. Age over 65 reduces B12 absorption naturally. If a patient is B12 deficient, the nerve sheath is degrading faster than it can repair itself. Gabapentin has zero effect on this. The nerve can't rebuild what it's missing. B12 deficiency neuropathy is actually highly reversible when caught and corrected early, which is exactly the kind of driver a root cause workup would find. Root cause number 4, inflammation and autoimmune triggers. A meaningful subset of neuropathy patients has an immune-mediated driver: Sjogren's syndrome, lupus, sarcoidosis, idiopathic autoimmune processes that don't have a clean label yet but are showing up in the inflammation markers. These patients are often on gabapentin for years without anyone ever running an immune panel. For this patient, symptom management is failing because the immune system is the driver, and no pain drug touches the immune system. So what does treatment look like when it actually targets the root cause instead of just the signal? Well, before we get to that, into the exact evidence, if this reframing is how you're thinking about treatment options, hit subscribe below. I go into this level of clinical detail every month, and there are more videos coming on this topic. Subscribe so you don't miss them. So what root cause treatment actually targets? Let me give you the actual evidence, not general wellness claims, but clinical results for interventions that target mechanisms gabapentin can't touch. Alpha-lipoic acid for oxidative stress. There is published meta-analysis showing that intravenous alpha-lipoic acid at 600 milligrams per day over 3 weeks produces clinically significant, meaningful reduction in neuropathic pain. And it does this by targeting oxidative stress in the peripheral nerves. That's not pain signal effect. That's an oxidative stress effect. It's working upstream of where gabapentin works. And the evidence goes further. A 12-month combination protocol, alpha-lipoic acid combined with B12 antioxidants and carnitine, showed improvements in nerve conduction velocity, pain scores, and sensory nerve action potential, and vibration perception threshold, which will affect balance. Nerve conduction velocity, that's a biological measurement and how well a nerve is actually transmitting signals, not how the patient rates their pain on a scale. That's the difference between measuring the fire alarm and measuring whether there's fire still burning. Metabolic optimization, getting blood sugar trajectory under control, changes vascular environments the nerves are operating in. This matters to the progression rate in a way that gabapentin doesn't have any effect on. B12 repletion, when B12 deficiency is the driver, the nerve sheath can begin repairing once the deficiency is corrected. That's a biological repair process. No pain drug can do that. The drug has no mechanism for it. Non-pharmacological modalities. A meta-analysis of randomized clinical trials on monochromatic infrared therapy in diabetic peripheral neuropathy showed improved sensory thresholds and reduced pain. These aren't fringe interventions. They're clinical tools published in evidence that simply is outside the standard pharmacological framework. They work on mechanisms the first line of drugs don't even address. Here's why this gap exists and why it's not, and really, your doctor's fault. So the framework in the gap exists, and I want to be specific about what I'm saying here. I'm not saying your doctor failed you. I'm not saying gabapentin is the wrong drug. I'm not telling you stop your medication at all. Don't stop any prescribed medication without talking to your prescribing physician first. What I am saying is that primary care medicine and general neurology are not trained in neuropathy subspecialization. That's not negligence, it's the structure of the medical training. A generalist approach to neuropathy does something reasonable. It matches a drug to a symptom. Patient has nerve pain. Here's a drug that helps with nerve pain. That's a logical response within the framework that a generalist is trained in. A specialist approach does something different. It matches an intervention to a mechanism. What is driving the nerve damage is in this specific patient really is the question. Is it oxidative? Is it B12 deficiency? Is it an autoimmune process? If nobody's screened for it, then what's the targeted intervention for the specific driver? Those are two different practices. They have two different outcome profiles. The generalist approach works well for acute management. It works for a subset of patients whose neuropathy mechanisms happen to match gabapentin and what gabapentin addresses. But it hits a ceiling, often very quickly, for patients whose driver isn't covered by any of the first line of pain drugs. Nothing more we can do often means nothing more within the framework I was trained in. That's not the same statement as nothing more exists. Every patient sitting on gabapentin prescriptions that stopped working deserves to know this. There is a category of treatment of your current approach isn't covering. The root cause side, really, of the equation. Identifying which driver is primary, oxidative stress, metabolic insufficiency, B12 deficiency, or immune triggers, requires an evaluation most patients never have been offered. That evaluation is what changes the conversation. Here's what I want you to take from this video. Standard first-line neuropathy drugs are symptom management tools. They do not repair nerves, address oxidative stress, correct for B12 deficiency, or resolve inflammatory triggers. Only 3 to 4 out of every 10 patients get meaningful relief from gabapentin at therapeutic dose. Most are on a drug that isn't matching their mechanism. For root cause categories that standard treatment doesn't screen for, oxidative stress, metabolic and vascular insufficiency, B12 and nutritional deficiency, and inflammatory or autoimmune triggers, root cause treatment, alpha-lipoic acid, B12 metabolic optimization has clinical evidence showing biological nerve improvement, not just pain score changes. And nothing more that we can do often means nothing more within this framework. It's not the same thing as nothing more exists or nothing can be done. If you want to go deeper on why gabapentin specifically stops working, the mechanism behind it, and the response rate data, that's a full video on its own. I'll link it here when it's available. If you're watching this because your neuropathy has been getting worse, while you figure out the next steps, the 7 warning signs video will give you a clinical checklist of what to watch for. That one's linked here. Subscribe if you want more of this kind of explanation. I keep these videos specific and clinical, so no generic advice.